طيب بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على سيد الأنبياء والمرسلين. It gives me a great pleasure to welcome all of you to the second session in this amazing meeting. It is my great pleasure to introduce the second speaker, Dr. Kristien Boelaert. Dr. Kristien has introduced yesterday, but for those who didn't attend the last yesterday lectures, I will briefly introduce her. Dr. Kristien is a professor of endocrinology at University of Birmingham and a consultant endocrinologist at University Hospital Birmingham. Her clinical research interests include the management of thyroid dysfunction, nodules, and cancer, as well as endocrine disorder in pregnancy. She was a clinical lead for NICE guidelines on thyroid disease and lead in national consensus statements on management of thyroid cancer and RCOG Green Top Guideline of Thyroid Disease in Pregnancy. Dr. Kristien is a senior editor for Endocrine Connection, BMC Endocrine Disorders, and the Journal of the Endocrine Society. She serves on the editorial board of several endocrine journals, including Lancet Diabetes and Endocrinology, Thyroid, and Clinical Endocrinology. Dr. Kristien is going to discuss and update us about a very important topic, management of low-risk thyroid cancer. Dr. Kristien, the mic with you.
I would like to thank the organizers for asking me to speak on the state-of-the-art lecture entitled Management of Low-Risk Thyroid Cancer. These are my conflicts of interest. Right, so as an overview of what I will be discussing, a few slides on the epidemiology of low-risk thyroid cancer, and then how we diagnose thyroid cancer. I have some information on the new risk stratifications that we use, and particularly for low-risk thyroid cancer, extent of surgery, as well as need for radioiodine ablation and TSH suppression. And then finally, I will move on to follow-up of these patients. What we are talking about in low-risk thyroid cancer is differentiated thyroid cancer, which, as this audience well knows, originates from thyroid follicular cells, which are these cells lining the thyroid follicles. And the cancers arising from these cells give rise to papillary and follicular cancers, which collectively are termed differentiated thyroid cancer. The vast majority of these are papillary cancers. And across the globe, over the last 30 years, there has been really an explosion of these thyroid cancers. You can see here the most recent data from Cancer Research UK, where you can see an exponential increase in the incidence of these thyroid cancers for all patients, particularly for women, but also for men. And in the United States, it's estimated that in 2022, there will be 43,800 new cases and about 2,230 deaths. There are actually some very nice new data which have originated from the United States, showing that since 2014, this explosion that we've seen of thyroid cancers may actually be slowing down. So this first panel here, so this is a study that's still on EPUB in thyroid, but this first panel here shows the incidence of papillary of thyroid cancer and then a mortality from thyroid cancer. And you can see that there is this big disconnect between incidence and mortality. When it was then looked at in more detail, you can see that this is actually slowing down since 2014, and this is particularly the case for papillary cancers, less so for follicular, medullary, and anaplastic cancers. And again, when you look at it by tumor stage, it is mainly the local cancers that have reduced in incidence, as well as the smaller cancers. Again, here it is these smaller cancers, less than 1 centimeter or less than 2 centimeters, that are slowing down, but not so for the larger cancers. So it seems that we are now picking up less of these very indolent, low-risk cancers, and that we are still picking up the more pronounced risk cancers. So I'd like to illustrate this with a case which will require a bit of audience participation, where I'll give you some time to think. So this is a 48-year-old man who presents with a 6-month history of a lump in the neck. He has no other symptoms. On examination, he has a palpable 1.5 centimeter right-sided neck lump and no palpable lymph nodes. He has a normal TSH, and his thyroid ultrasound, which is depicted here, you can see that he has an irregular thyroid nodule with some microcalcifications, which is hyperechoic and which has some internal vascular flow. So this is rated as suspicious, a TI-RADS 4 score, or in the United Kingdom where we use the U scoring, a U4, but they're very similar. And there were no suspicious cervical lymph nodes on ultrasound. And then an FNA is undertaken, and this confirms that this is a malignant Bethesda class 6 lesion. So the question is, what would you recommend? So what we have here is a 48-year-old gentleman with a 1.5 centimeter thyroid nodule that's suspicious for thyroid cancer. Do you suggest that he has a total thyroidectomy and radioiodine ablation, a right lobectomy? Do you send the FNA specimen for further molecular testing, or do you recommend active surveillance of this lesion? So I'll just give you a few seconds to think about it, and then I'll tell you what I would do with this. So my suggestion here would be that we do a right lobectomy for what seemingly might be a low-risk thyroid cancer. And if I was giving this talk on how to manage thyroid cancer about 10-15 years ago, things would be quite simple. And essentially, the way in which we manage thyroid cancer for many, many years are based on these data from 1994 from Mazzaferi, which is really a landmark paper. So what this showed was a relatively heterogeneous group of patients with differentiated thyroid cancer who were followed up over 30 years. And what's given on the y-axis is here the percentage of recurrence. And you can see that patients who underwent thyroidectomy only had the highest rate of recurrence. This was reduced in patients where TSH suppression was given, but it was most reduced in those patients who were given radioiodine ablation and then TSH suppression with T4. And that led to the widespread recommendation that all patients with thyroid cancer should have a total thyroidectomy, should have radioiodine ablation, and should then have suppressive therapy with levothyroxine. More advanced cancers would also be treated or may be treated with external beam radiotherapy, chemotherapy, or a number of targeted therapies. And this still remains the case to date, but that is not what we are talking about today. So we in our clinic have patients who were told about 20 years ago that they will require follow-up lifelong in our clinics. They've all had a total thyroidectomy, remnant ablation, and TSH suppression. And the realization that actually a lot of these thyroid cancers, the differentiated thyroid cancers that we see, are actually low risk, resulted in a number of new ways of stratifying patients. So the standard way in which cancer is stratified is still a TNM staging. And this is a very good system. So it's based on the tumor size, on the presence of lymph nodes, and on the presence of distant metastasis. And this is a very good system to predict death from disease and overall prognosis, but it does not take into account individual treatment responses, and it does not accurately predict the risk of recurrence. And of course, patients with low-risk thyroid cancer tend not to die from their disease. So what was then first proposed by the American Thyroid Association, but which has been adopted by most current guidelines on how to risk stratify these patients, is a new post-operative risk stratification system, where following surgery, thyroid cancers are rated as low, intermediate, or high risk. So intermediate risk are those cancers that have microscopic invasion or presence of cervical lymph nodes, or which have slightly more aggressive histology than a classical type biliary cancer. And high risk tumors are those with extrathyroidal invasion or distant metastases. And you can see that this is a continuum of a spectrum. Again, here, this is taken directly from the American Thyroid Association guidelines. You can see this is divided into low, intermediate, and high risk. With low risk tumors, those that are intrathyroidal, so no extrathyroidal extension, and which may have up to 5 lymph nodes where micrometastases are present. And again, this goes into more detail here of what constitutes a higher risk to higher risk going up as we sort of go up on this graph here. Sorry. So What's also been introduced by most of the scoring systems is then a dynamic risk stratification, because essentially what we need to determine is, once the patient has completed their treatment, what is going to be their risk of recurrence. And this is something that's being used in many different cancer settings. So at about 9 to 12 months, when the patient has completed their treatment, they should undergo a neck ultrasound and have measurement of thyroglobulin and thyroglobulin antibodies. And this will then help us to subdivide patients into those with an excellent response to treatment, those with an indeterminate response to treatment, and those who have had an incomplete response. Incomplete is then further subdivided into biochemical incomplete. So this is where there is a rising thyroglobulin concentration, or structural incomplete, where you find imaging evidence of what patients have had. And of course, the way in which this is subclassified very much depends on the initial treatment that the patients have had. And a lot of the low-risk thyroid cancer patients are now treated with lobectomy only. So those who have an excellent response will have negative imaging and undetectable thyroglobulin antibodies and a stable thyroglobulin if this is measured. So we do actually have some relatively long-term follow-up data of patients with low-risk thyroid cancer who were treated with lobectomy only. So this is a nice study where you can see 40 years of follow-up of 295 patients who underwent a lobectomy for thyroid cancer. And the bottom line and the main message of this paper is at the bottom here, where you can see that 95.6% of patients remained in remission during this 40-year period of follow-up. There were some patients, up to 18%, where there was a further development of suspicious disease, but you can see that the majority of these patients were actually treated successfully with rescue surgery. So there was some recurrence present in 13%, but this was adequately treated with rescue surgery. And the bottom line is that less than 5% of these patients had any evidence of disease during the 40 years of follow-up. Higher recurrence was observed in those patients who had an intermediate risk on post-operative risk stratification, those with more aggressive histology, and those who had larger tumors that were greater than 4 centimeters. This is from the European guidelines, the ESMO guidelines on management of thyroid cancer. And again, what we're looking at here is differentiated thyroid cancer with no lymph nodes, so N0 status, either a T1A or a T1B or T2 tumor, and you can see that if there are no additional risk factors present, that active surveillance may actually be a reasonable option. There are a number of patients, and I think this needs to be discussed with the patient, where a lobectomy is still advisable, and so this applies to tumors that are less than 1 centimeter. For tumors that are over 1 centimeter, generally, if there are no additional risk factors, a lobectomy would be recommended. And if there are additional risk factors, or if there is evidence of extrathyroidal extension or a family history or history of radiation, then more aggressive treatment may be needed. But so the patient that we discussed was someone with none of these additional risk factors, who had a T1B tumor where a lobectomy would be certainly the initial first advisable step. So there are now a number of studies that have looked at active surveillance of these patients, and a lot of these studies actually come from Korea, where, of course, in Korea, a lot of patients have ultrasounds and they find a lot of low-risk cancers. So this is part of what's being used for the updated American Thyroid Association guidelines, a systematic review that has looked at 7 studies of 1,200 patients who were managed by active surveillance. So most of the data is limited to tumors that are less than 1 centimeter. And it appears that active surveillance is similar for these low-risk small PTCs in respect of mortality, risk of recurrence, and other outcomes. However, it was commented that the data remain very heterogeneous, and there are a number of methodological limitations, and that a number of confounding factors really cloudy the waters here. And the recommendation of this meta-analysis is that further research is needed, certainly for non-papillary cancers, those that are greater than 1 centimeter, and in older patients. Going back to our case then, we have a 48-year-old male who indeed underwent a hemithyroidectomy. His pathological diagnosis was of a well-differentiated biliary thyroid cancer, which was 1.8 centimeter in maximum diameter. There were no adverse features, so no extradural extension or vascular invasion, and it was rated a T1B, NX, MX, R0, so it was completely excised. And on a staging CT, he had no cervical lymph nodes, no distant metastases. And then the next question is, what would you recommend now? Do you suggest that he has a completion thyroidectomy followed by remnant ablation, that he has no further surgery, but that we suppress the serum TSH, or that he has no further surgery and that we aim for his TSH to be in the lower half of the normal range? Again, I will give you a few seconds to think about this. And here is what I do. I think this patient does not need any further surgery, but that we can monitor him and that we should aim for his TSH to be in the lower half of the normal range. Again, this is algorithm that's taken from the ESMO thyroid cancer guidelines, and this relates to which patients need to have radioactive iodine ablation. And again, what we're looking at here is the left-hand side of this algorithm here in the low-risk thyroid cancers. So certainly the PT1A, the less than 1 centimeter tumors, no radioiodine would be recommended. In other low-risk cancers, so this is the PT1B, radioiodine may be optional, and certainly if there are additional risk factors, radioiodine, as per these guidelines, would be advised. With regards to radioiodine, again, about 15 years ago, everybody had exactly the same dose of 3.7 gigabecquerels of radioiodine when they undergo remnant ablation. We've then had two trials, HILO and estimable trials. The HILO trial was done in the United Kingdom, where 438 patients with T1 to T3 tumors were randomized to receive either 1.1 gigabecquerels or 3.7 gigabecquerels, and either this was done under thyroid hormone withdrawal or with recombinant TSH. It was a non-inferiority trial, and the success of ablation at 6 and 9 months was not inferior. So this shows that for these low-risk thyroid cancers, a lower dose of radioiodine is as effective as the higher dose, and that recombinant TSH is as effective as thyroid hormone withdrawal. And of course, recombinant TSH results in far fewer side effects and discomfort for patients undergoing this. We've then, in addition, because of course this is a relatively short follow-up period, we've then had a further follow-up study of these patients who were followed up for a median of 6.5 years. And again, you can see that there was no difference in longer-term recurrence between the lower dose when compared to the higher dose. And there was also no difference in recurrence whether recombinant TSH or thyroid hormone withdrawal was given. So if you give radioiodine for most of these low-risk cancers, a low dose under recombinant TSH is what would be advised. And then very recently, this is just a couple of months ago, in the New England Journal of Medicine, there was this very nice further trial that has actually looked at giving no radioiodine versus low-dose radioactive iodine for low-risk thyroid cancers. So these were tumors that went up to T1B, and all tumors were lymph node negative. So there were 387 that were just managed with follow-up, so no radioiodine ablation, and then 389 that underwent radioiodine ablation. And again, this non-inferiority trial showed that not giving radioiodine was not inferior to giving radioiodine. And when you look at during the 3-year follow-up period at functional events, so this is the finding of structural disease or biological events, this is the finding of a raised thyroglobulin, there was no difference in patients who were not treated with radioiodine compared to those who were treated with radioiodine. And so the conclusion of this paper is that patients who have a thyroidectomy for low-risk differentiated thyroid cancer, giving radioiodine was probably not necessary, and thyroidectomy alone for these patients is sufficient treatment. Again, lending further support that we probably should be giving less radioactive iodine. Moving on then to TSH concentrations, because this is the third pillar of the way in which we used to manage these patients. i.e. we used to tell them you need to have a TSH suppression for the rest of your life. This is a large study looking at 5,000 patients who underwent a lobectomy for biliary thyroid cancer between 2000 and 2012. And essentially what these graphs here show, either for a mean or a dominant TSH concentration, that regardless of where the TSH was for these low-risk cancers, it actually made no difference to their disease-free survival. Recurrence rates, again, were very low, a total of 1.4% during 5.6 years of follow-up, and so the disease-free survival was not affected, indicating that TSH suppression in these low-risk thyroid cancers is probably not necessary to prevent further thyroid cancer. And of course, on the other side of the coin here is the risks that we are well aware of that are associated with TSH suppression and that are associated with both endogenous and exogenous subclinical hyperthyroidism, which is essentially what we're inducing in these patients when we suppress their TSH. This was 901 subjects who were treated for differentiated thyroid cancer, again over a long period of time. And you can see that patients who underwent TSH suppression had significantly higher rates of cardiovascular disease, particularly arrhythmias and atrial fibrillation, compared with matched control patients. And this was particularly so when TSH was kept less than 0.1 milliunits per liter. There are additional risk factors associated with TSH suppression, again, as we are all aware, factors relating to bone mineral density, as well as cognitive impairment. This is a further study specifically looking at patients who have had differentiated thyroid cancer. So this is from a database looking at 3,800 thyroid cancer survivors, and particular risk factors here for cardiovascular disease were identified. And you can see that suppressive TSH therapy was an independent predictor of development of increased cardiovascular risk. This was in addition to older patients having an increased risk and patients who had cardiovascular disease at baseline also having an increased risk, but TSH suppressive therapy was an independent predictor. And again, relatively new data looking at bone mineral density. So this is a meta-analysis of 17 studies. You can see 739 patients with differentiated thyroid cancer and 1,085 controls. And it's particularly in postmenopausal women that you can see that TSH suppression will be associated with an increased risk of reduced bone mineral density at the spine. So this is bone mineral density at the spine in postmenopausal women. This was not present in premenopausal women and was not present in men. So it seems to be that these women particularly are at high risk of developing lower bone mineral density, bearing in mind that this is not trial-based, this is all based on observational studies. So most guidelines, this is taken from the American guidelines, but most guidelines will recommend that you do a risk-benefit ratio for these patients. So you look at the risk associated with TSH suppression and then the risk associated with the cancer. So patients who have had an excellent response are highly unlikely to need any TSH suppression. As the response to the treatment increases, your threshold for giving TSH suppression will be much lower, taking these other factors into account, where certainly in those with incomplete responses, we would give moderate or complete suppression, even if they have any of these other risk factors, but they are something to be taken into the equation. What about follow-up? Because again, like I said, we have told many of these patients recurrence can occur up to 20, 30 years later. We need to keep you on our books, but of course, our clinics cannot manage looking after all these patients. So the newest British Thyroid Association guidelines, which I have led on, propose that we offer discharge after 5 years if there has been an excellent response to dynamic risk stratification, and particularly if there is no recurrent or residual disease, TSH is within range, and there are no thyroglobulin antibodies. Patients who have had a lobectomy only may require some follow-up because, of course, they will still have half a thyroid lobe in situ, and remote consultations will be very useful here. With regards to thyroglobulin measurements, it's proposed that you use a sensitive assay and that you take thyroglobulin antibodies into account, as well as other factors that may interfere with the measurement of this. It is often a trend in consecutive measurements that is more significant and more informative. So a doubling of a thyroglobulin is something that is really quite informative. For most of these patients, we can do an unstimulated thyroglobulin, so there's no need to stimulate with recombinant TSH, and a second generation assay with a good functional sensitivity is generally advised. In patients who've had lobectomy, only thyroglobulin measurements may be difficult to interpret, and further evidence is coming from the fact that on the day that patients have remnant ablation, the thyroglobulin measurement really is a good predictor. If it's undetectable at that time, then that really is a very good prognostic factor. With regard to imaging during follow-up, again, what we're looking at here is the sort of the left-hand side of this panel. So patients who've had an excellent response probably need very little by further imaging, whereas patients where there is, of course, an incomplete or a structural residual, that more frequent cross-sectional imaging may be required. In summary, less is more in the management of thyroid cancer. There is recent evidence that the low-risk thyroid cancer epidemic may be slowing. This has an excellent prognosis with a low risk of recurrence. Newer approaches such as active surveillance and lobectomy seem to be very useful. We are giving less radioactive iodine and we are doing less TSH suppression. And it's important that thyroglobulin is measured on a sensitive assay and that the newer risk stratification systems are taken into account. Thank you very much.
Thank you, Dr. Kristien, for this excellent update about follow-up of low-risk thyroid cancer. Unfortunately, there is no question and answer for this session, so we'll move to the second session. Thank you very much. Thank you for attending and thank you for listening for the lecture.